The Lancet launched its first series on global mental health in the year 2007. And at that time, many of us were involved with the series. In fact, the lead editors were myself, Shekhar Saxena, and Martin Prince. And there were many authors of that series who are present in the room here today. We wondered, would this just be a dry academic exercise, or would we as academics want to see something come out of this that was beyond just a series of papers in a journal? As good as a journal as it might be, it would still just be a series of articles. Over the following 2 years, we worked together, 1 year I think, to actually put into place the foundations of the movement for global mental health. So really the movement actually owes its origin to the first series on global mental health published in 2007. In the year 2009, we organized the first summit in Athens. Many of you were there. And at that time, another editor of the Lancet, Richard Turner, who was there, I suggested to him that maybe in another 2 years' time, it would be a good idea to review what progress has been made since the 2007 series. And this is a credit to the Lancet, to Richard Horton, the editor-in-chief in particular, for his unstinting support to global mental health, that within about a couple of hours of me sending an email suggesting another series, he'd already replied saying, fantastic idea, let's go with it. I think another very important point that, again, I should be very grateful to the Lancet is the idea that the series topics wouldn't be chosen by academics, but be chosen by civil society. No doubt, of course, the movement is not only civil society, but I count all the academic members who are members of the movement as de facto members of civil society. So, for those of you not familiar with how the article topics were chosen, here's what we did. We actually posted a call for ideas on the movement website. This is an example of how you can be involved in the movement. These are the sorts of things that happen on the movement website that you heard about a little earlier from Ritz. We got several hundred ideas from different members of the movement, and a core group of volunteers, amongst whom in fact are some of the lead authors of the series now, synthesized these ideas, got the advisory group of the movement to rank which were the ones that were most relevant in terms of either gaps in the literature in the previous series, or which could review the progress that had been made since the previous series. So that's how the topics were chosen, directly from the movement and by members of the movement. Subsequently, I invited my two co-editor colleagues. Apart from Niall, I have to acknowledge the very important contribution played by my co-editors, Shekhar Saxena and Pamela Collins. And one of the first things we thought about was, who do we invite as lead authors? It's not an easy task to invite lead authors, because the most natural thing one would do is to invite dinosaurs like myself. Although I've discovered I'm not that old, actually, Niall, but I'm not going to disclose how old I am. But nevertheless, it seems to me that the real vitality of a field lies in the renewal of its leadership. And Shekhar, Pamela and I felt collectively that what we wanted was 6 fresh faces. Maybe not fresh to all of you here, but certainly fresh in terms of leadership of major articles in a journal of the stature of the Lancet. So we then looked around, saw who in the movement has actually been active academically in the selected discipline, the selected subjects, and has an established record of publishing in that area. And so the 6 lead authors were selected on that basis. They then put together a group of 52 authors who are involved in the 6 articles that you'll hear about in a moment. And I'm delighted to say that 40% of those 52 authors live and work in a low and middle income country. And if you add the additional 15% who work in multilateral agencies like the World Health Organization, that will mean more than half of all the authors represent the developing world in one way or the other. I'm also very delighted that in selecting our authors, we were very careful about gender balance. We haven't achieved the optimum 50-50 balance, but we've gone a long way to improving the 2007 series balance. And also that more than a third of the authors in our 52 are in fact working in NGOs, civil society groups, including groups who represent people affected by mental illness. So this has been an endeavor, a joint endeavor of the movement and the Lancet, and I hope that you will all find that the science that the 6 pieces bring together really advances our field and will reinvigorate the movement and its cause.
I'd like to invite the first speaker, Crick Lund, please. Right, good afternoon everybody. It's really helped my mood today to hear myself being referred to as fresh-faced. That's the thing that first crosses my mind when I look at myself in the mirror in the morning. So I'd like to thank you all for this opportunity. It's a great honour to be involved in this process and to have been involved in this particular paper. This really was a team effort, so I'd like to begin by paying tribute to Mary De Silva, Sophie Pargison, Sarah Cooper, Dan Chisholm, Jishnu Das, Martin Knapp, and of course Vikram, who provided the overall mentorship and support and has been a tremendous support to me personally over the last few years. The focus of this particular paper, the first paper in the series, is on poverty and mental disorders, breaking the cycle in low-income and middle-income countries. Now, the work that went into this built on a platform that we developed as part of the Mental Health and Poverty Project, which was a DFID-funded consortium working from 2005 to 2010. And as part of that work, we conducted a systematic literature review on poverty and common mental disorders in low and middle-income countries, and found quite clear evidence that poverty was very strongly associated with common mental disorders. In other words, people who live in poorer communities in low and middle income countries are at greater risk of developing disorders like depression, anxiety disorders, and somatoform disorders. And poverty is associated not only with increased prevalence, but also with increased severity, longer course, and worse outcome. Although a lot of that literature was cross-sectional in nature, some of it is longitudinal, some of the emerging data is longitudinal, and from that and from the data from high-income countries, we've started to piece together something of the causal relationship between poverty and mental illness. And it's best described in terms of a cycle. So while poverty is marked by things like economic deprivation, indebtedness, low education, unemployment, lack of basic amenities, inadequate housing and overcrowding, these provide very fertile conditions for increased risk for mental ill health through causal pathways like social exclusion, high levels of stress, the daily grind of living in poverty, the uncertainty about food, the uncertainty about being able to provide for one's child's education, reduced access to social capital and a safety net, malnutrition, obstetric risks, and violence and trauma. All of these increase risk for mental illness. They lead to poor care or a lack of care and a more severe course to the condition. On the other hand, mental ill health in itself is a cause for poverty. And this is through a number of mechanisms, specifically through the increased health expenditure that's associated with mental illness, through loss of employment and through reduced productivity. And the top arrow is often referred to as the social causation pathway, and the bottom arrow as the social drift pathway. So it's social conditions of poverty which cause mental illness, and on the other hand, mental illness leads to a drift into poverty or remaining in poverty as a result of the illness. And there's some evidence from high-income countries that the top causal pathway may be more applicable to common mental disorders like depression and anxiety, and the bottom pathway to more severe disorders like schizophrenia and intellectual disability, epilepsy, and so on. Although this is complex and both pathways probably apply to most disorders. Now, related to this work, there's been increasing international recognition of some of these relationships. So the WHO Commission on the Social Determinants of Health in 2010 published this book, in which a chapter appeared on poverty and mental illness, focusing on depression and ADHD. And in the same year, the WHO published its Mental Health and Development Report, which provided very compelling evidence that people with mental disorders were a vulnerable group who should be targeted for development assistance. And partly as a result of this report, the UN General Assembly Declaration on Global Health and Foreign Policy acknowledged that mental health problems have huge social and economic costs, and actually cited this report, which was a joint product of the WHO and the Mental Health and Poverty Project. So all of this then begs the question, what interventions are required to break the cycle of poverty and mental ill health in low and middle income countries? More specifically, should such interventions target the economic circumstances of the poor, in other words, intervening in the social causation pathway, the top arrow that you saw, or should they target the symptoms and disabilities associated with mental ill health, intervening effectively in the social drift pathway, which was the bottom arrow? So this is what we try to answer in this particular paper, and in a sense the subtitle of this paper could be a tale of two systematic reviews. First of all, we conducted a social causation review and asked this question: Do poverty alleviation interventions improve mental, neurological, and substance disorder outcomes in low and middle income countries? And secondly, from a social drift perspective, do mental health interventions improve individual and family or carer economic status in low and middle income countries? In both reviews, we included individual and cluster randomized control trials as well as non-randomized interventions. And in the social causation review, we were interested in quantitative estimates of the effect of a poverty alleviation intervention on MH-gap priority M&S disorders. And we included in the review interventions like cash transfers, microfinance, loans, and so on. We excluded in-kind interventions such as food relief or nutrition supplementation, as well as employment and education. In the social drift review, we were interested in quantitative estimates of the effect of an intervention that was targeted at mental illness on the economic status of the individual or their family. And we included a broad range of interventions, including pharmacological, psychological, and psychosocial interventions. So this is what the first review looked like. I'm not going to go through all the details. Suffice to say it was an exhaustive and exhausting process. We started off with around 3,800 abstracts, and through various exclusion processes and double screening, ended up with only 5 papers in the final review. And similarly for the review 2, sorry, you can't really see that, that's 9,132 abstracts, and ended up with only 9 papers in the review. And all the details of this and the methodology are set out in the paper. You're welcome to have a look at that. So these were the interventions that we identified. So review 1, remember, was targeting the social causation pathway, and we identified studies which evaluated conditional cash transfers, unconditional cash transfers, loans, and asset promotion programs. And then targeting the social drift pathway, we identified family psychoeducation, group or individual psychotherapy, psychiatric medication, community rehabilitation, residential drug rehab programs, and epilepsy surgery. So I'm just going to speed up a little bit. For the 4 studies, comprising 5 articles, which were included in Review 1, there were these countries involved, and essentially we found mixed results. Some conditional cash transfer and asset promotion programs were quite clearly associated with mental health benefits, specifically improvements in behavioral problems in children and cognitive development in children. But some showed negative consequences. So loans, for example, led to increased stress. So taking loans is bad for your mental health if you're considering taking one yourself. The intervention effects seem to be dependent on the precise nature of the intervention, the conditionality, and the level of input. And so we really need to explore and tease out more of what the precise causal pathways are involved in these interventions. For Review 2, we had a slightly larger data set of 9 studies from these countries. And among those, we had 18 economic status outcomes, 13 focusing on the individual and 5 on the family or household. And here, very encouraging news, there was a clear trend that mental health interventions showed improved economic outcomes in low and middle income countries. Of the 19 associations that were tested, 10 showed a significant positive effect on economic status, and 9 showed a non-significant yet positive effect. None of them led to a negative effect. And benefits were shown not only for individuals, but also for households and families. Part of the challenge is that not all the interventions are suitable for scaling up, but some were. There were 3 relatively simple, brief interventions developed by Paul Bolton in Uganda, by Vikram Patel in India, and by Dr. Chotalia and colleagues in India, which are good candidates for scaling up and do show quite clear economic benefits. So just to highlight, improvements in economic status go hand in hand with clinical improvements in all studies, and that's very, very encouraging and supports the broader call to scale up mental health care. So priorities for future research are: we need more high-quality studies in low and middle-income countries. We need to develop robust, locally relevant and multidimensional economic outcome measures. And an interesting area of future potential research is to assess the macroeconomic consequences of scaling up. So if we know that there are benefits at the individual and household level, how could we quantify potential benefits at a macro or national level? And the policy recommendations are essentially to scale up mental health care. Mental health interventions do carry clear economic benefits, and there is potential there to break the cycle of poverty and mental ill health. And we need to improve monitoring of mental health outcomes in poverty alleviation interventions. The absence of evidence doesn't mean evidence of absence, and we need to explore this area further. So I'd just like to conclude by acknowledging our funder, DFID, which supported our work in the Mental Health and Poverty Project, and now subsequently in a program called PRIME, which we're just starting up, and also our work at the Centre for Public Mental Health, which you're welcome to have a look at. Thank you very much.
Thank you very much.
Good afternoon. So this is the final talk, so hopefully everybody's still awake. The topic that I was addressing is around human resources for mental health, current situation and strategies for action. And I, again, like the other presenters, I have to thank all the authors who were involved in putting this together. And the mentorship and support that we all received from the Lancet group, the editorial board and so forth, and the discussion with the other authors from the different papers. It was an incredible learning experience. So why focus on human resources for mental health? I think I don't really need to put in too much of a case for this. I think everybody knows. And the WHO series of atlases that look at various resources really sort of provide the evidence that there are shortages for mental health professionals to provide services, and there are large variability in the availability of services across the different countries. And of course, the call to action by the Lancet really sort of put forth to the need to scale up coverage of services for mental disorders in all countries, especially in low and middle income settings. So we know what we're supposed to do roughly, but how do we take this global evidence and then what can we do in our own settings to achieve the kinds of things that we aim to achieve? For people who are involved in this field, if you haven't seen this already, I hope you can go to the website and look at this document. It's the WHO 2006 World Health Report called Working Together for Health, which really talks about human resources of health, generally speaking. And addresses the fact that at the heart of each and every health system, the workforce is central to advancing health. I think in the area of mental health, this is particularly the case, where many of the types of interventions that we need to provide are led and provided by service providers. And in order to do that, effective leadership and management for human resources for mental health will be essential in addressing key challenges in scaling up services that include things such as mobilization of financial resources, recruitment, retention, equitable distribution of workforce, and so forth. And this framework is available on the WHO website for anybody who's interested. So in our paper, what we want to know is, what is the current status on human resources for mental health? What are the needs and wage bill to eliminate the shortages that we have in workforce in low and middle income country settings? And what is the available evidence on the effectiveness of mental health services and training for detection, treatment, and care by specialist and non-specialist health and community workers in low and middle income settings? In terms of looking at the current status and shortages, the two sources of data that we looked at, one Dr. Saxena presented earlier today and talked about is the World Mental Health Atlas 2011, which is another atlas, a survey that is carried out approximately every 5 years and covered 183 countries. In terms of the shortages and the wage bill, we looked at another recent publication that was published through the WHO, which is the workforce shortages, that was led by Richard Scheffler, which estimated the actual shortages of mental health resources, workforce resources, based on the WHO aims and the Global Burden of Disease report. And this covered 58 countries in low middle income countries, and then estimated how these might be applicable in other low middle income settings. So what we found from these reports is the median number of mental health workers in the country groups are presented in this particular table. What we know is that the psychiatrist had the highest number and median increase in psychiatrists in high-income countries only. As it was addressed before this morning, in terms of low-middle income countries, they haven't made the kinds of achievements that we had hoped. The largest workforce within the mental health system are nurses, and the biggest median change over time was also among nurses. In terms of the needs and shortages, what we know is that we need, based on the 58 countries that were involved in this report, and what we need is roughly 362,000 mental health workers. This relates to about 22.3 per 100,000 population in low-income countries and 26.7 per 100,000 in middle-income countries. And the distribution of the workforce that was reported in the report is around 6% for psychiatrists, 54% for nurses in mental health settings, and 41% for psychosocial providers. In terms of the shortage, what that means is the shortage is about 239,052 mental health workers. That's the number that we need to train to meet the needs of the mental health workforce. In terms of what is it going to cost to actually eliminate this shortage, and these are based on the 58 countries again, and this is just looking at the salaries of the mental health providers. The annual wage bill relates to about $820 million US dollars. Which breaks it into about 80 million for psychiatrists, $420 million for nurses, and $314 million for psychosocial care providers. And so what really this emphasizes is that it's critical to really think about mobilizing financial resources to address this issue, and strategic changes in the payment system need further exploration to be able to address some of these issues. In terms of the review that we did, so what is the evidence on service delivery and training? The approach that we took was that we asked some of our co-authors to put together case examples, and we have 3 from India, Sri Lanka, and Indonesia that addresses some different aspects of addressing human resources for mental health. We also did a literature review looking at Medline and PubMed using existing validated search strategies that are available online. And the details are provided in the paper, but we also looked at hand-searching journals, scanning the reference list of relevant articles and websites of pertinent organizations, for the same reason that what Julian had said before, that it's really difficult to find the kinds of studies that we needed to find. We included non-randomized and randomized trials that looked at detection, treatment, and prevention of mental disorders and training of mental health workers. And the workforce that we included are specialist workers, non-specialist health workers, and other professionals. What we found are 63 studies, 42 which addressed the interventions and looked at patient and caregiver outcomes, and 24 studies that looked at training on capacity outcomes. The study locations, we won't go into detail about these, you can see these in the paper. And the key findings is that the mental health care can be delivered effectively in primary care settings through community-based programs and task-shifting approaches that engage and support skilled and non-specialist health professionals, lay workers, affected individuals, and caregivers of mental health service delivery. So not only do service users have a role in doing research, but also in service delivery. And I think this is a key point. And what we also found is the composition of the mental health workforce will vary across different countries according to the population needs, mental health service delivery systems, and resources. And the composition will vary because different countries have different mechanisms, different staff have different functions in different settings. So a social worker in one country may not be doing something completely different from a social worker in South Africa, for instance. So it's really thinking about different functions of each of the staff roles. Mental health specialists should and will continue to play a central role in delivering services and in training, supervision, and monitoring. Short-term training and ongoing monitoring and supervision of non-specialist health workers and community workers can improve confidence, detection, treatment, and care. And the human resources for mental health are likely to worsen unless substantial investments are made in effective strategies. In terms of staffing, a skills mix approach as opposed to a staff mix approach, I think, is the approach that should be taken, given the different mechanisms in the different settings, and a broader workforce needs to be adapted. Training should be relevant to local needs. Institutional capacity strengthening is critical. And better leadership and management. I think that's it.
So I need to thank a few people quickly. First of all, just to tell you how this program was put together, again for those of you not sure, the program was put together exactly like the Lancet series by the movement. Ideas were solicited from members of the movement and a group of 12 young volunteers. I think they're all young, but I like to keep saying they're young because maybe they're younger than me. Volunteers put the program together and then organized everything. In particular, I'd like to note the contributions by Ritz, you've already heard, Lawrence, who chaired the morning session, and Valentina. I'd like her to stand up because she hasn't been on stage yet, who has been a fantastic job in organizing the travel bursaries that I will talk about in a moment. I'd like to thank all the facilitators, but in particular those who you may not have seen in the last session: Sharon Kleinchis, I hope I pronounced your name correctly, Sharon, John Copeland, and Harry Minas. I want to particularly thank the hosts of this meeting, that's Cape Mental Health Society. I can see Brian Robertson and Ingrid Jacobs I can't see, but I'd like to particularly thank both of them, and also the conference organizers, Natalie Kensley and Ingrid Daniels in particular, who've given outstanding support. I have to again point out, the summit has no organizers. The movement doesn't have an office, it doesn't have a bank account, so the whole thing is run in this incredibly organic way. There's no secretary, there's nothing. Well, now there's a secretary, but there wasn't for this particular summit. So the whole thing's run entirely on volunteers. And so it's important to acknowledge that this whole effort is a success in spite of the lack of any backbone structure to the movement. I have to thank the solitary funder that has contributed to the summit, and that's the Wellcome Trust. The Wellcome Trust provided money to allow the first 100 registrations to the summit to be free. So for those of you who didn't pay, we'll thank the Wellcome Trust, and also 11 travel bursaries given to 11 people from developing countries, mostly researchers, but also several that went to people representing user groups. So I'm very grateful to the Wellcome Trust. And finally, the one person who probably the most to make this summit happen, unfortunately, in fact, isn't with us here today. So I have to thank her in absentia. She's a Cape Townian, but sadly she's been stolen by the WHO, and so she's now in Geneva. That's Sarah Skeen. Sarah really is the person who has played a central role in making this summit happen, and I think all of us miss her greatly today, and I'm sure she misses us as well. So it just remains for me to say that I hope we see all of you and many more in 2 years' time. I don't know where the next summit is going to be, but I'm sure Harry and his secretariat will organize something and let us know in the near future. So thank you again. The World Federation opening session begins at 6:30. All the lead authors of the Lancet series will be milling around. If you want to ask them more questions, you have a chance. Thanks again for staying with us the whole day. Thank you, Niall, and have a good evening.